that in due time. But we're moving on to a new topic, and that's on humidity, and this chapter anyways, humidity and bland aerosol therapy. Once we get through this chapter, then it's time to test again. So yeah, I know. Bless you. So we'll do, again, chapter 39 in two parts. We'll do part 1 today, part 2 on Wednesday. To be honest, chapter 39 is not exceptionally long. It's not like the airway management chapter that had so many parts and pieces inside of it. So this one, and again, timing's everything, I guess. And so please know I did not have the football schedule pulled up when I was doing this semester's assignments. Specifically because tomorrow you have a test, right? Again, I wasn't planning on Monday Night Football and the Jags playing, and then, oh yeah, there's going to be a test the next day.
Are you sure?
We can
I'm sure.
push it to another day if you want to.
Yeah, I can't do that. But, in looking at what I have to cover today, I bet you we will get out of here at a much earlier time than usual. So let's see how long it takes me to get through part 1 here of chapter 39. I will give you some sort of break, at minimum 30 minutes break, and then we can start the second class maybe a little bit earlier if I don't go on too long on this. Then maybe we can start the second class a little bit earlier, get through that, and then you guys can have the rest of the afternoon to yourself to maybe review for tomorrow's test, so you can watch football or go to the tailgate. And I know you're going to study at the tailgate, of course. Who would, to get ready for tomorrow's test. Before I forget to mention it, however, there is a homework in this class, the fundamentals, homework quiz assignment number 3 that is due on Wednesday at 11:59 p.m. So please don't forget about that. I'll try to remember to remind you guys Wednesday when we do part 2 of this. If there's any questions, and I'm not going to go fast, it's not my intention to get you guys out of here early, but just looking at the stuff going, okay, that's not going to take me that long to cover or talk about. But please feel free to ask questions as they come up. Some of this stuff, believe it or not, we have already talked about. So it's kind of exciting to be able to say, hey, this part of this is kind of a review of stuff we've already mentioned earlier. So humidity, and that's where we'll kind of open up. We won't even talk about bland aerosol therapy today. We're strictly going to talk about humidity. Bland aerosol therapy will be a part of the second part that I'll do on Wednesday. But humidity, and I don't think anybody in Florida that's asked what is humidity, we all know what humidity is. We walk outside, we're all showered, cleaned, hair did up, everything, ladies, makeup done, or guys, makeup done, you're looking good, you walk outside, and what happens? Muggy. It all goes to hell, just like that. Because of the moisture that is in the air. So it doesn't matter what we do to try to prevent it. No, it's like I got to get from AC to AC so I don't sit there and sweat myself to death because of the moisture that's in the air. Now we know moisture's in the air. We know even today it's not exceptionally hot, but it is muggy, it is humid. We can't see the moisture in the air, but we know it's there. We can feel it. So humidity by definition is water in a gaseous or molecular form. Again, something you can't necessarily see. The size of the particles is way too small, but we know the moisture is there. And its quantity depends on the temperature of the gas. And so we know here when it gets hot, it even is more muggy or more humid feeling because there's more moisture in the air. The terms absolute humidity and relative humidity we have talked about on a previous chapter. Again, that's stuff that we will be testing on next week. But just a little bit, and we'll get back to that in just a second. So heat and moisture exchange. Primary function of the upper respiratory tract, primarily the nose. We know that the nose warms, filters, humidifies the gases we breathe. And it is the nose that primarily helps to heat and humidify the gas that you and I are breathing in right now to help to moisturize it. The nasomucosal lining of our upper airway and our nose is kept moist by secretions that we know are constantly being produced. The mucosa of the sinuses, even the trachea, bronchi aid in humidifying inspired gases similarly. But please remember, what of these structures, nose, sinuses, trachea, bronchi, primarily does the moisturizing or humidifying? It is the nose. It is the nose. Even though we say the trachea can do some of that, the bronchi can do some of that, yes it can, but primarily humidification, heat and humidification should be occurring in the upper airway, primarily the nose. All right, so as inspired gases move into the lung, they should achieve BTPS conditions. BTPS. BTPS, anybody know what that stands for? Body temperature, pressure, saturated. BTPS. Body temperature, pressure, saturated. Meaning, by the time the gas moves into the lung, it should be at BTPS conditions. Meaning, at a body temperature of 37 degrees Celsius, which of course, remember, that's normal. That could be a good question for tomorrow's test. Which we know that's a normal temperature. At barometric pressure we are in right now, saturated with water vapor, meaning it is carrying 100% of the moisture that we need. 100% relative, I can even say 100% body humidity, because we know what we need. And the inspired air that we breathe in, again, by the time it reaches the lung, should be fully saturated. Meaning by the time it reaches the isothermic saturation boundary, it should be carrying how much water? 44, if you remember that number. 44 milligrams of water per liter of gas. That's what makes it fully saturated, 100% saturated. When we, and I'll get to this a little bit more in just a minute, but we should always be targeting that number when we're trying to heat and humidify the gases that we're providing our patients. I will say this, the oxygen that's in the walls of the hospital, that we plug in that flow meter to, that we connect our oxygen tubing to, that we connect our ventilators to, our BiPAP, our CPAP systems, that oxygen coming out of that wall outlet, you know how much moisture it's carrying? Zero. Nothing. Nada. Absolute bone dry. There is absolutely no moisture whatsoever in that piped in wall system. So that gas that's coming out is carrying zero moisture. Has to be that way. If not, you'd have moisture, you'd have contamination inside the walls and all those oxygen piping systems. So it has to be bone dry. Another reason, if we connect it to our equipment, like a ventilator, CPAP machine, BiPAP machine, that could damage the internal components of those equipment. If there's moisturized gas getting inside of our equipment. So think about all that stuff coming to that wall. It is bone dry. And if we're providing that to our patient, okay, be mindful. Sometimes we don't need to add moisture. If, for example, the patient is still breathing through their nose, they can still moisturize their inspired gases. But if they're not able to moisturize their inspired gases, we better make sure we are providing BTPS conditions to our patients. All right, so above the isothermic saturation boundary, and again, where is the location of the isothermic saturation boundary?
5 centimeters.
Just below the carina. If this represents the carina, it is just below. 5 centimeters below approximately, just below the carina. Which in my mind, I'm still thinking, okay, by the time that gas hits the carina, it better be carrying 44 milligrams. Better be BTPS conditions. But technically, isothermic saturation boundary is just a tick below the carina. So, above the isothermic saturation boundary, temperature and humidity vary during inspiration and expiration. But below, it should be maintained. Should be relatively constant. Doesn't matter if the breath is going in or coming back out. Heat and humidity should be constant below the isothermic saturation boundary. Now, reasons that boundary, that ISB, isothermic saturation boundary, could shift distally, further down, deeper down into the airway. If the person breathes in cold, dry air, again, maybe that overcomes the upper airway's ability to heat and moisturize. If the airway is bypassed, ET tube, tracheostomy tube, what are you bypassing? All the mechanisms that normally provide heat and moisture. And again, think about the gas that's coming out of that wall outlet, and you're attaching that to somebody's ET tube or trach tube, bone dry gas. Or if their minute ventilation is higher than normal. I'm glad we've already talked about minute ventilation, so I don't have to explain that now. But if they're, and how does one increase their minute ventilation or make their minute ventilation higher than normal? Take deeper breaths and or faster breaths, or a combination of all of that stuff. So maybe, and again, you guys do not have high minute ventilations right now, but what about that patient in distress? That's huffing and puffing, breathing lots of air. Their ability to properly heat moisturize can be affected. All right, so the shifting can affect the body's normal heat and moisturizing components. We know during inspiration, air is warmed and humidified. The air that you and I are breathing in right now is being warmed and humidified. And when we exhale, some of that heat and moisture is recovered by the mucosal walls, by the mucosal lining. Some, not all of it, but some of it. When we provide proper heat and humidity, we help to ensure normal function of the mucociliary transport system. I know we've talked about cilia already in the past, and I've alluded to some of what we're going to discuss today. Honestly, back then I'm trying to hold back and try not to reveal too much information because I know at a later point today we're going to be talking about that stuff. So if we don't properly heat and humidify someone's inspired gases, what are we damaging? What are we affecting? Their own ability to clear foreign particles, mucus, from their lungs. All right, so some numbers here, and yeah, probably say some of these numbers you probably need to be somewhat familiar with, in case I ask. So when we think about what we're breathing in now, and again, I'm not talking about oxygen concentration, so just avoid trying to plug in a 21% anywhere in here, all right? I'm not talking about oxygen, I'm talking about moisture. Moisture. If we're breathing in regular room air, proximate temperature around 22 degrees Celsius, which is like 72, 73 Fahrenheit, ballpark. Room air is carrying about 10 milligrams of water per liter. Maybe a little higher in Florida when it's humid out, but generally in the room right now, there's about 10 milligrams of water in the air that's floating around out here. We know ultimately by the time it gets to our isothermic saturation boundary, however, it should be carrying how much? 44. All right, so we breathe it in. We breathe in that gas. By the time it reaches the naso and oropharynx, so naso-oropharynx, approximately this location here, God bless you, it is being warmed, so we're already picking up of 10 degrees Celsius, but notice how much moisture, approximately 31. So from 10 out in the room, up to 31, just by the time the inspired gas reaches our oral and nasopharynx. Again, because the nose does most of the humidification. By the time it reaches the trachea, how much moisture is it carrying? About 40 milligrams per liter, 40 milligrams of water per liter of gas. All right, so by the time it hits the trachea, about 40. We're almost to 44. But by the time it reaches the carina, or just slightly below the carina, that isothermic saturation boundary should be heated up to normal body temperature and carrying how much? 44 milligrams of water per liter of gas. Again, fully saturated. And so that's how it normally is supposed to work.
So if somebody has a fever, will it be move the temperature? Will it be increased to whatever the fever is?
Well, body temperature could be, yes. But it's not going to carry additional moisture. Okay? So temperature can change based on fever, etc. But it's not going to necessarily change the moisture level. So how it is supposed to work. Now when we inspire, we say our normal mucosal lining is adding what? Heat and moisture. My little H2Os, they're all jumping into the gases that are going down, right? So heat and moisture, again, provided by the epithelial lining during inspiration. During expiration, we exhale heat and moisture, but guess what? Some of it is retained back to the mucosal lining. So some of that moisture, even though we do exhale heat and moisture, some of it does go back into the mucosal lining. Again, if I just bounce back a slide, so this could happen again. So we're kind of reusing some of our previously used exhaled heat and moisture each and every time we breathe. But us being respiratory therapists, especially after last week's lab, what did we introduce? An ET tube. And guess what cannot penetrate through the ET tube?
The water.
The water. Heat can get in there, but the water can't. So again, what did I say about the oxygen that's coming out of those wall outlets?
Dry.
Bone dry. And you're providing bone dry gas down the endotracheal tube, bypassing what? Every mechanism that was capable of providing, or what should have been providing most of the heat and moisture, correct? Until that gas gets out of the endotracheal tube, and that's at what approximate location?
Right below the
Above the carina, right, the endotracheal tube just above the carina, you know. Did we talk about placement? 3 to 5 centimeters above the carina. So picture, we'll just use 5 for pick a number. So if in our example, the endotracheal tube of our patient's exactly 5 centimeters above the carina, we're a proper location. Gas is now exiting the endotracheal tube, and it's carrying how much moisture?
Not much.
Nothing, right? Because what's coming out of the wall outlets? Nothing.
Zero.
And so normally that gas that was probably almost carrying 44 milligrams of water right now is carrying nothing. So what's the remaining portion of the trachea and bronchi and the lower airways going to attempt to do? It's going to attempt to add moisture. It's going to attempt to. Okay, it's going to try to add moisture to the inspired gases that we did not provide. Okay? Now, you know, we should provide, but in my example, we didn't provide. So, when the endotracheal tube bypasses the upper airway, and that's going to happen every time we intubate a patient, we're bypassing the upper airway, or even trach a patient, we're bypassing the upper airway. Cold, dry medical gases are now delivered to the lower trachea or bronchial region. And that area is now forced to contribute to try to moisturize the inspired gases. And so what happens? Without adequate humidity, the airway surface, airway epithelium becomes damaged. We reduce the movement of the cilia or ciliary motility. Mucus production increases, and secretions become inspissated. That is the word of the day, inspissated. What does that mean? Dry. Bone dry. Think about and again, our normal secretions, we know are sticky, and we know there is some moisture that's there with it. The body, lower airway region now, that is trying to contribute moisture, is going to do what to that moisture that is normally lining the airway? It's going to try to take it. It's going to try to steal that moisture from our airways, pulling the moisture out of the secretions, leaving the secretions what? Dehydrated. Dehydrated secretions. So the secretions become super thick, super viscous. And we're expecting the patient's cilia to keep moving that stuff upward and forward. It's not going to work very well. All right, so what's pictured on the left is normal BTPS conditions. You can see the cilia kind of in motion here. There's the mucus. There's some foreign particles that are stuck on the mucus, but the cilia still can pull that stuff and move that stuff forward. here's our inspissated secretion. What happened to all the cilia? They died, right? They became uprooted because instead of, if you remember how the cilia flow through the mucus, pull the mucus forward, they disengage from the mucus, clean themselves off in that watery layer, re-engage the mucus and bring the mucus forward, disengage. Well, guess what they can't do now since we're stealing all the water? They can't disengage from the mucus and clean themselves off. So they get stuck in this mucus, trying to pull it upward and forward, and end up unrooting themselves from the columnar epithelial cell. And so then you end up with this desert-like surface with very little moisture. And again, who are these patients? These are pretty sick patients that need a breathing tube, a trach tube, an endotracheal tube, and now we're robbing their own natural defense mechanisms. No wonder that particular patient or those particular patients have such thicker, more viscous, nasty secretions that we still will go down and attempt to suction out. But why is the secretion so thick and so hard for us to remove? Because we're not providing adequate humidity. And so my big thing is, why don't we stop this from happening by doing what? Providing adequate humidity in the first place.
Does the temperature of the air also contribute to how thick the mucus is?
Not necessarily the thickness of the mucus. Temperature, which I will talk about here in just a second, does affect the capacity to carry more moisture. But in this example, since I'm not providing an adequate amount of moisture, the body's stealing that moisture from the airway epithelium. All right, so going back to some of the terms we've talked about before, absolute humidity, that's an amount, the amount of water. All right, absolute humidity, just a physical amount. Relative humidity is that amount divided by its capacity, how much that gas can possibly hold. And so when we talk about relative humidity, it's always a percentage. Percentage of the amount it's currently carrying divided by its capacity. And so we can see it as a percentage. Body humidity, very similar to relative humidity. Body humidity is still the amount, or absolute humidity, divided by its capacity, how much it can hold, but how much does the body want? The 44 number, right, that we've talked about since probably day 2 in the program. All right, so when we talk about body humidity, we know the body requires 44 milligrams. And so when you have a humidifier, and at some point we will say, okay, I have this whole grouping of humidifiers, and I say, okay, which one can provide 100% body humidity? There's going to be some that can, and there's going to be some that cannot. Okay, so obviously when we say it's providing 100% body humidity, it's something that's capable of carrying 44 milligrams of water per liter of gas. The term humidity deficit. 44 is still a very important number here for humidity deficit. So if you know you're providing your patient with a humidifier that provides less than 44 milligrams, less than, and we can pull a number out of the air, but if you provide something that provides less than 44, then the difference between what you're providing and 44 represents the humidity deficit. And I do have a couple examples we'll look at here in just a second. Okay, everybody okay with that? Absolute humidity, relative humidity, body humidity. I know we've talked about that, I think from chapter 6. All right, so here's my question. Of all the humidifiers we have laying out in front of us, we grabbed this one, whatever this one's supposed to be. And this one we said can provide 30 milligrams per liter of humidity. My test question is how much body humidity can that device provide? You grabbed a humidifier that can provide 30. Okay? How much body humidity will that device provide? How do you figure that out? You need to take 30 and divide it by 44. Remember, I'm not going to tell you 44. I'm not going to tell you that's the magic number. You have to remember that's what, to provide adequate humidity, 44 needs to be provided. Okay? All right, so what's the answer? Anybody that's done it? About 68. So I'm just taking 30 and dividing it by 44. All right. So you know when next week we have a test, I'm going to give you this exact same question, change it, make it a little more structured, make it a little, maybe folks look at it going, but it could be something different. No, I'll still give you the fundamental basics that's in this question. I'm not going to give you 30 as the question. I'm going to make up a different number, but it's whatever that humidifier can provide divided by 44. Okay? What if we picked a humidifier that can provide 44? Then what would be the body humidity? 100%. 100%. Next question, again to this one, what is the humidity deficit? Again, the device can provide 30. Somebody said it? 14. Okay, so the difference between 44 and what that device is providing. But again, remember, on the test, I'm not going to give you 30. I'm going to pick another number. And you clearly see the math's not difficult. It's not complicated. So humidity deficit is simply subtracting 44 from whatever the humidifier is providing. To figure out body humidity, take whatever the humidifier is providing and divide it by 44. Come up with a percentage. And everybody snap a picture of that if you want it. That's everything, all the math that's necessary here. But just remember on the test, I'm going to give you a different number than 30. Okay, so these answers will be different. Any questions on that before I continue? All right, let's talk about indications for humidification, your humidity therapy. Primarily to humidify those dry gases we're providing, that dry oxygen that we're providing from the wall outlet in the hospital, especially at higher flows, okay? Flows of 4 liters or higher, for example. And I know we haven't talked about oxygen devices yet. That's coming in just a couple weeks. I know you've been introduced to some devices already. That's just to make you look smart when you get to clinicals. If there's a little bit of knowledge up there so you know what you're looking at. And we will, like I said, talk about all the different oxygen delivery devices in the coming weeks here real soon. But if you're providing, and I know you guys have all know what a nasal cannula is, standard regular nasal cannula, at 1 liter, at 2 liters, do I need to humidify that? No, that's a very low liter flow, and plus the patient's own upper airway still is contributing to heat and moisturize the inspired gases. It's when the flows get what I would call kind of up there a little bit higher, 4 liters or higher, that it would be a nice thing to provide a little bit of moisture for your patient. And we'll talk about how much moisture we're really providing here, even though the patient's own upper airway is still intact and still capable of providing their own humidification and own moisture. Second one, again, about that patient with a bypassed upper airway. Overcoming the humidity deficit that would exist if we didn't provide humidity to our patient with a bypassed upper airway, which could include an endotracheal tube or tracheostomy tube. Secondary reasons, patients with thick, copious, or bloody secretions, patients with body temperatures less than 32 degrees Celsius, or patients with high spontaneous minute volumes greater than 10 liters, which is nearly double what our normal minute ventilation is. There may be indications in that case to probably provide some additional moisture for the patient. All right, so clinical signs or symptoms of inadequate airway humidification. And again, just because a patient, number one, atelectasis. Now this does not mean, oh, this patient has atelectasis, we must provide them humidity. No, if we don't provide a patient humidity and their secretions become extremely thick and dehydrated, there's potential for mucus plugs to form. If that happens, mucus plugging within the airway itself,